Dr. Jyoti Raghuram, a senior consultant pediatrician with special interest in pediatric rheumatology at Aster Women and Children's Hospital, Whitefield. And I'm here to speak to you today on respiratory allergies in children and what we have seen in the last couple of years with respect to COVID-19 in particular. So, as you know, respiratory allergies are quite common in children, and we have basically two commonest allergies, which are the allergic rhinitis and asthma. So there can be comorbids with any of these conditions, such as allergic rhinitis can be associated with asthma, it may be associated with sinusitis or adenoid hypertrophy, and asthma also may be associated with allergic rhinitis as a comorbid condition. So what do we mean by allergic rhinitis? So when there are symptoms of runny nose or nose block or itchy nose, rubbing the nose frequently, itchiness or pricking sensation in the eyes, rubbing eyes frequently, or if there is a sneezing in the mornings. These are all the symptoms of allergic rhinitis. And at any time, one or the other symptom may be more prominent. Some children may have morning sneezing and nose block. Some children may have evening itching or a nose block in the nights, and they may be fine during the day. Some children just have this symptom of rubbing the nose or doing this or rubbing eyes, this is called actually an allergic salute. And some children may have dark circles around the eyes because of frequent rubbing, which are called allergic shiners, or a line on the nose which is called Darier's line, which is again due to allergy. So this is a frequent complaint that we find, and parents come and tell us that, doctor, my child is just not sleeping well at night, seems to be having some discomfort, or in the mornings for an hour or so child is sneezing, has some discomfort, continuous sneezes 10-20 times, but rest of the day the child is fine. So depending on the severity of the symptoms, we decide whether child needs medication and what medication. So if the symptoms are more than for 4 days a week, generally lasting for more than an hour, then we do take it as significant. If it is less than 4 days a week and less than, say, half an hour of just less than an hour in a day, then it may be taken as mild intermittent, and the child may or may not need medication. Along with medication, the first step would be to prevent the triggers. So triggers are similar for both allergic rhinitis and asthma. Asthma I will discuss in a few minutes, but the triggers are usually the same. Commonest being dust, in the house dust due to the dust mite, and smoke exposure, strong smells, talcum powder, molds on the walls due to dampness or fungus. These, and of course pollution, air pollution. A season change can also trigger, that is beyond our control, but things which we can control are typically within the home environment, which are easily preventable. For example, dusting frequently when child is not at home is helpful. Wet mopping of the floors is helpful. Something that can be considered is using dust-proof covers on pillows, on carpets, on mattresses, because these cannot be cleaned very frequently. And where possible, blankets, sheets have to be washed and air dried in hot sun. That was also helpful. Smoke exposure, preventing the exposure to cigarette smoke, cooking smoke, incense, sprays from perfumes, air fresheners, room fresheners, the mosquito repellents, all these will definitely help. Okay, and same thing goes for strong smells, perfumes, deodorants, and also avoiding talcum powder. The dust inhaled from talcum powder application can again trigger both allergic rhinitis or asthma. Air pollution outside, we can't really do much, but better to keep the windows closed. If you're staying in a dusty area during the peak hours, then better to keep the windows shut. The other triggers exposure to cold air. So again, better to avoid going out when it is very cold, and keeping the windows shut at night to prevent the draft of cold air. Wall-to-wall carpeting helps if the floor is very cold, but at the same time it increases dust mite. So we usually avoid wall-to-wall carpeting. Things like curtains, fans, which are not cleaned on a daily basis, we have to take extra effort to get these also cleaned and keep the house dust free. Pest control is again very important, as roaches, cockroaches and other pests can trigger an attack. So it's better to use effective non-smelly pest control measures and keep the house pest free. So there are both, the intrinsic factors and the extrinsic factors which trigger allergies. Intrinsic is something which may be inherited. If the parents or grandparents have allergies, then again child may be at an increased risk for allergy. So any child who comes with these symptoms, we do ask for a detailed family history. Sometimes parents forget or they don't feel that is significant. But even if mother or father has allergic rhinitis, then that can be one of the risk factors for children with asthma. If grandparents have asthma, for example, we had this baby admitted in our intensive care unit who came with history of fever and cough and breathing difficulty. And the elder sister had a similar history of cold cough and was treated at a clinic with a pediatrician at an outside clinic, and she had improved fairly quickly. So this looked more like a viral flu or a lower respiratory infection, and it was just last month when COVID was at its peak. So we did rule out COVID and we admitted the child and started treatment for a lower respiratory infection. Parents initially denied any other family history of allergies or asthma, and this was a 9-month-old or a 10-month-old infant who had not had any breathing difficulty episodes earlier. This was the first episode. So we treated for infection, but soon it became apparent that there was no significant bacterial infection. There was no pneumonia on the X-ray, and it appeared to be a mild viral which had triggered quite a bit of breathing difficulty in this baby. And as the baby continued to have wheezing, we treated with all the measures for both infection and wheezing. But on a repeat questioning, the father did come back to tell us that there was a significant family history. The grandmother had asthma, and the older sibling had an episode of hospitalization similar to what this baby had few years back, requiring nebulizations and medications. So sometimes these episodes may be severe, needing admission in ICU and needing more treatment apart from just the regular treatment for the allergies or asthma. Hence, a family history becomes very important, as preventive measures are advised by us to prevent these episodes from recurring. So how do we treat allergic rhinitis? Avoidance of triggers is the first thing, and second step would be what we call antihistaminics. So these are available as syrups or tablets, anti-allergy medicines. The older generation or the first generation antihistaminics they cause quite a bit of sedation, so they are not much recommended. Second generation antihistaminics like cetirizine, levocetirizine, fexofenadine, avastin, loratadine, these are what are preferred in children and can be given for infants older than 6 months of age and children above the age of infants and children above the age of 6 months. So these help to control the symptoms of allergy effectively. It can be used on a need basis if the symptoms are only intermittent, or if it is a more frequent symptoms, then it can be given as a preventer for a short period of time on a daily basis. There are something called leukotriene antagonists, that is montelukast, which can be given in combination with cetirizine or levocetirizine depending on the symptoms. But what we prefer for treatment for allergic rhinitis is a nasal spray called intranasal steroids. These are locally acting nasal sprays. They contain a very low dose of the steroid medication, which is typically mometasone or fluticasone, furoate or propionate, which will act to decrease the inflammation in the nose at the nasal mucosa level itself, and prevent the allergy from increasing, from going down to the air passage and causing further problems. Over a period of time, they help to reduce the inflammation in the nasal mucosa and decrease the symptoms significantly. The side effects that we see with antihistaminics are not seen with the intranasal steroids. So children who go to school can develop sleepiness because of antihistaminics. Some children develop constipation. So, and these cannot be used for very long. So we prefer, if the symptoms are more frequent, then intranasal steroids would be the first line of treatment, preferred line of treatment. It is important for parents to understand that these have to be given for a period of anywhere between 4 to 8 weeks, sometimes up to 12 weeks. And this acts as a preventive measure, reduces symptoms significantly. Even after stopping, the children generally remain symptom free for a period of 2 months. They are not curative. No allergies can be cured completely with just one course, but it can be controlled. So this would be the preferred line of treatment for allergic rhinitis, along with avoidance of triggers. And these have to be given on prescription basis by your pediatrician. So if your child has symptoms of these allergic rhinitis, like what I described earlier, do take your child to your pediatrician and discuss the treatment options. Coming to asthma in children, so asthma is basically a constriction of the air passage. Many parents or many people are under the impression that asthma is a lung problem. Basically, it's not an inflammation or infection in the lungs. It is a bronchospasm or a constriction of the air passage that leads to a feeling of tightness, chest tightness, difficulty in breathing, coughing or wheezing. Wheezing is a whistling sound that is heard because of constriction of the air passage and a difficulty in obstruction during exhalation or during the expiratory phase. So if it is mild, there may be only a nighttime cough, or there may be cough only after play or exercise. Again, in asthma also, we have the classification or grading of the severity based on whether it's mild or moderate or severe, and based on whether the symptoms are intermittent or persistent. So Indian Academy of Pediatrics has given guidelines for treatment, for grading severity and treatment. We also follow what is called the GINA guidelines, Global Initiative for Asthma, which describes how the asthma should be graded and treated based on the severity of symptoms. GINA also has a lot of patient education. So I would recommend any of you who have these symptoms to look up the GINA website and look up the patient education information on that, which is very useful. So when a child comes to us with these symptoms, sometimes it may be very clear. Parents have noticed recurrent or repeated episodes of cough, wheezing, or the nighttime cough, breathing difficulty, chest tightness, waking up in the middle of the night with difficulty in breathing, then it is clear. Or sometimes it may not be so clear, like how I said, a young infant who was admitted with wheezing following first episode of viral infection. Or sometimes they may just come with an effort intolerance. They may just say that my child gets tired after playing for a short while and does not want to run or play like other children do. So is there any issue, and what could be the, is there a problem with the lungs or the heart of my child? And sometimes there may not be continuous symptoms, but there may be 1 or 2 severe episodes in a year which happen typically with season change. So child may be fine for most of the year and may not need any medication, or may have had mild symptoms which have gone unnoticed. And when season change happens during the onset of the monsoon or the winter, the child may experience an episode which can become severe very quickly. So it is important for parents to know that asthma can be life-threatening. These children may need hospitalization, they may need ICU admission, or they may need very intensive treatment if it is not being controlled. So it's very important to control asthma symptoms, to follow up with pediatrician regularly, to continue the medications as advised. So for asthma, again, depending on the severity and the frequency of symptoms, the treatment is decided. And the preferred evidence-based recommended treatment is by inhalers. So the inhalers, or the puffs what are called, are available as both controller medication and reliever medication, and these have to be given by just as an inhaled way using what is called a spacer or a spacer and mask depending on the child's age. So the inhalers are safest, very low dose. They are preferred because they are targeted therapy. They go directly to the air passage where the action is needed, unlike oral medications which need to be absorbed from the blood and are not as effective as inhalers. So our most common misconception amongst parents, or the doubts that we face from parents when we advise inhalers are, Doctor, aren't these addictive? You're prescribing inhalers to my child. I have heard that these are harmful. I have heard that this contains steroids, and we don't want to give inhalers to our child. He just had a cough episode. He doesn't have asthma. So, and these kind of questions are very common, which we can understand come from the parents' understanding of asthma or the misconceptions. So inhalers are very safe. They can be given for years. They don't make the child dependent, and they don't make the child resistant to treatment either. It is not that if you give it for months or years, the child will stop responding to the treatment. No. And it is not the inhaler which makes the child get these repeated episodes. It doesn't mean if you give it for some months and we stop it and the child gets the episode, we have made the child dependent. No. It's important to understand that asthma is a condition which can recur. It is a reversible airway obstruction. So it is, the reversibility may be mild initially, it may be quick, and symptoms may get reversed even without medication. But if these episodes keep happening on a regular basis, and then the severity also may increase, the reversibility is not so easy, and the child may come with a severe episode at any point of time. Hence the need for treatment. If it's a reversible condition, why should we treat? Parents ask. This is the reason. Because as airway inflammation happens again and again, it leads to airway remodeling. The airway diameter becomes narrow because of swelling in the air passages due to the secretions, due to the inflammation, and that leads to a decrease in the reversibility of the whole thing. So if your doctor has diagnosed your child as having asthma and prescribed inhalers, kindly take it seriously, give the medications as advised, and follow up with your doctor on a regular basis, even when your child is not showing any symptoms. So the controller medication or preventive medication is typically an inhaled corticosteroid, again at a very low dose. The reliever medication is like salbutamol, which is a bronchodilator. It helps to dilate the air passage, but does not prevent anything to prevent the inflammation, does not do anything to prevent airway remodeling. So if your child is needing too much of bronchodilator or too frequent bronchodilator, that is not a good thing. More than 2 times a week or 3 times a week, then it means your child definitely needs to be on controller medication. A combination inhaler is also available. The combination of steroid with a long-acting bronchodilator, which helps to control the symptoms better than just the bronchodilator or just the steroid. So the doctor will take a detailed history, check the child, and then prescribe which inhaler is best suited. Dry powder inhalers are also available, and after discussing with parents based on child's age, the ideal medication is prescribed. Along with the inhalers, sometimes leukotriene antagonists like montelukast can also be given to prevent the severity of asthma. So again, the prevention of triggers, like what I discussed about allergic rhinitis, the same thing holds good for asthma also. Last word about allergies and COVID-19. So parents were very anxious that COVID can worsen the asthma, or what to do if my child who has asthma contracts COVID-19. Fortunately, we have not seen really any increase in the severity of COVID-19 in a child who has asthma or an adult, unless it was a very poorly controlled asthma. If someone had severe symptoms but were not really showing their doctor regularly, were not taking the prescribed medicines regularly, obviously, like any other viral infection, COVID-19 can aggravate the asthma, and these people can end up in hospital. But as such, COVID-19 really did not aggravate any underlying asthma. Also, we saw that in the last 2 years, because majority were indoors, wearing masks, following good hygiene, respiratory hygiene also, the incidence of asthma attacks, allergies had come down, just like how influenza infections had come down. Children were not going to school, so the incidence of viral infections was less, and viral infections are a frequent trigger for allergies and asthma. So that was also less in the last 2 years. But those who did not have a good control, those who needed oral steroids for control of their asthma, if they got COVID-19, they needed hospitalization. There was an increase in the severity of illness and also deaths in such cases. Also, then coming to the immunization against COVID, vaccines, are they safe in children with allergies and asthma? So generally, vaccines are safe in most people, even with allergies. It is a reaction to the vaccine is very rare. But if your child has had a reaction to any vaccine, like say measles or MMR, which contains the egg protein, then you should inform your doctor that and take the vaccine, COVID-19 vaccine, in a protected setting, or in a, say, like a hospital setting, where any allergic reaction, if it happens, can be dealt with immediately. We do advise the parents to wait for 15 minutes to 30 minutes after the vaccination in the hospital to check if any allergic reaction happens. But generally, even for children with food allergies or insect bite allergies, they do not really have an allergy to the vaccine, so it is safe. Of course, has to be given after one-to-one discussion with your doctor. And it is a good idea to give the vaccine, just like the influenza vaccine, to children with allergies and asthma, in order to prevent a severe attack due to a viral infection such as COVID-19 or the influenza virus. So I guess that would be the discussion. And for today, I've covered allergic rhinitis, asthma, triggers, the prevention, and the management. And also recently highlighted the what we have seen recently in these last 2 years with COVID, and just a note on vaccination of children with allergies and asthma. So thank you for a patient hearing. If you have any questions or doubts, feel free to post on the chat box. I will get back. And I'm available for consultation at Aster Women and Children's Whitefield. We have a specialist, allergist and pulmonologist too, and you're welcome to reach out to us for any concerns. Thank you.